I have been dealing with HPV for over 30 years. What is human papillomavirus? Or better, what are human papillomaviruses?
What is HPV infection and what does that entail?
HPV is a family of viruses which comprehends almost 200 different types. They behave like different viruses and are responsible of different kind of diseases. Papillomaviruses are classified with numbers from 1 to more than 150 different genotypes. Number 1, number 2, number 4, number 7 are responsible of common warts in the hands and the feet. Number 6 and number 11 are responsible of genital warts, and these are the so-called low-risk viruses. Anogenital warts are being treated with surgery, laser, cryotherapy, or local application of creams, but they easily come back again. But at least they have nothing to do with cancer. But they are few, it's a small group. The majority of these viruses are higher risk viruses, which may cause a high-grade disease on the long term, eventually leading to cancer. But what is wrong is to make the equivalence HPV equals cancer. Cancer is an extremely rare complication of an extremely common condition. Sometimes I used to make the comparison with the lottery. You have to buy the ticket if you want to try, but it's not enough to buy the ticket to win the jackpot. The same is true as far as regards HPV. There is no cancer of the uterine cervix without HPV. But within HPV, you won't necessarily win cervical cancer.
How common is it and what are the risk factors?
The problem is that it is very easy to come in contact with one or more HPVs. Because while HIV is transmitted through blood or seminal fluid, papillomaviruses are transmitted through direct sexual contact, skin and mucous membranes. So many women come in contact with one or more HPV, and more HPV types does not necessarily mean more sexual partners. A woman may have had only one sexual partner and turns out to be infected by even 6, 7, maybe 8 different types, while a woman may have had several sexual partners without being infected at all. And it is not easy to identify the spreader. It's very chicken and egg. But it is true that approximately 70–80% of sexually active people are infected during their lifetime. So 7 women out of 10 is a great number. It's like you gather your 10 best friends in one room and you say, come on, raise your hand, he who has been infected with the HPV virus. You would expect 7 women raising their hand, and you would realize that only 1, 2, maybe 3 will do that. Why? Not because they don't want to tell, but just because they don't know. Because HPV may remain latent for months and even for years, like in a sleepy state, and theoretically for the rest of your life. So many people are free of disease, but may harbor the virus for years. So there are no signs of lesion, we see nothing, but the virus can be detected through DNA testing, but without causing problems in the vast majority of individuals. But it also can be reactivated in those cases where the immune response is weak. It's like a war between the virus and the human body. When your immune system is strong, the virus can stay dormant for years. But when there is an immunodeficiency, for instance, HIV, organ transplantation, use of corticosteroids for long periods, autoimmune disorders like systemic lupus erythematosus, rheumatoid arthritis, thyroiditis, and so on, smoking and other kind of drugs, physical and emotional stress, if someone dies in your family, if you have to move, if you are under pressure. Remember, cigarette smoking prevents the elimination of the virus. So please, no smoking. You have to quit as soon as possible.
What is the natural history of the disease?
We have just seen that the latent infection can reactivate, as well as a new one can be acquired. But luckily, about 18% of people get rid of it. They can spontaneously eliminate the infection. Easy come, easy go. But persistence or progression may occur in some people, not necessarily the weakest, though more frequently the most immunodepressed. And it is the persistence for many years of these viruses that might lead, only in some people, to a precancerous lesion over time. But the good news is that it takes a long time span before causing cancer, so we have enough time to intervene. It may take between 8 and 12 years from an HPV infection to invasive cancer, sometimes less, sometimes even more, and some other times never. In any case, we generally have time. So we can follow up most of these low-grade lesions without the necessity of removing part of the uterine cervix. Uterine cervix, which we know it's important in preventing miscarriages and preterm deliveries in the future. Also, if we immediately remove a low-grade disease, we have to remember that it can easily recur because we don't eliminate the virus. And we are not willing to cut slices of uterine cervix all the time. Also because we jeopardize future follow-up if the cervix is improperly treated. But we need to be sure that the patient is compliant to the recommended interval of time to be checked again. So patient adherence is very important.
How is it treated in different situations?
If it is true that the most frequent infections are caused by high-risk HPV types, it is also true that 70–80% of these new infections are cleared within 1 year, and as far as 90% or more clear in 2 years or more. In an old study, it was demonstrated that nearly 30% of female students tested positive for HPV DNA within 1 year of first intercourse with a first male sex partner. And by 3 years, almost half tested positive. And this is the reason why HPV testing should not be performed under the age of 30. By age 50, at least 4 out of every 5 women will have been infected with HPV at one point in their life. What about HPV types? We know that about 70% of cases of cervical cancer are due to HPV 16 and or 18. 15% are due to other 5 HPV types, HPV 31, 33, 45, 52 and 58. About 80–90% of anal cancers are due to HPV 16, 18, and 90% of anal genital warts are due to HPV 6 and 11. All these types that I've just mentioned are included in the new vaccines, so that protection is about 90% for both cervical cancer and genital warts. But we should remember not confuse risk with grade. High-risk viruses are the most common HPV types, but they can cause a low-grade disease, also known as CIN1, where we see a spontaneous regression in 1–2 years or even more, avoiding overtreatment, or a high-grade disease, also known as CIN2 and CIN3. And these lesions need to be excised because they could lead to an invasive cancer over time. Once the treatment was called conization, but cold knife conization could possibly create problems for future pregnancies. Today we have new techniques, laser excision or LEEP, which means loop electrosurgical excision procedure. These procedures can be performed with local anesthesia, strictly under colposcopic guidance, as outpatient procedures, and we remove only selected areas, avoiding removal of large amounts of cervical tissue like it used to be 30 years ago. HPV testing may be useful in some situations, provided it is used properly. HPV test is not to be recommended to screen women less than 30 years of age. These girls must be screened with the pap smear. It is not recommended more often than every 5 years in women over 30 years, in adolescents and young adults with any kind of abnormality, in the management of low-grade lesions under 30, when a high-grade lesion has already been diagnosed. It is not recommended in males as well as in anatomical sites other than the uterine cervix. Testing for low-risk HPV types is not recommended, as well as to screen for sexually transmitted diseases. HPV testing can't make diagnosis. It only selects a population of women at risk. What makes diagnosis is the pap test, colposcopy and biopsy.
Let's see some pictures and the relative available treatment.
Colposcopy is the direct visual inspection of the cervix and the vagina after magnification and gentle application of particular solutions. Diluted acetic acid reveals the most intimate patterns of the lesion, while iodine staining improves visualization of abnormal areas and the margins of the lesion. Here we can see a normal uterine cervix with its peculiar pale pink color. If negative, a pap smear can be repeated after 2-3 years. There's no need in repeating a cervical smear every single year. In the cases of low-grade lesions, and remember that we don't have to confuse between risk and grade, a high-risk virus may cause a low-grade disease. In these occasions, we see white areas, which sometimes we call mosaic, because they are just like, you see, little white bricks. But this is a reassuring colposcopic pattern, and we may possibly take a biopsy, but usually these women may be checked back again in 6-8 months without the need of a surgical treatment, because these lesions can regress. In the cases of high-grade lesions, CIN2, CIN3, so a high-risk virus causing a high-grade disease, we see an irregular mosaic. We see an atypical pattern. You may realize a disruption of the general architecture, and these are the cases that need treatment in the form of what we call LEEP, loop electrosurgical excision procedure. Procedures that can be done under local anesthesia. We perform 3-4 injections of an anesthetic drug similar to that used by the dentist, but these are not painful procedures. And we are able to remove only the interested area in the shape of a half sphere. What remains immediately after the treatment is a sort of crater, but the good news is that the uterine cervix is able to grow back again. Of course, not like the nails, but we can see a regeneration of the uterine cervix, so that after 4, 5, 6 months, it may return back to the normal state without compromising future fertility or pregnancy outcomes. Of course, it depends also if the lesions are small or if the lesions are large. In the first case, we will remove only a small portion of the uterine cervix, while in the cases of larger lesions, we will have to perform larger excisions. Let's get through some other pictures. Genital warts. Genital warts are caused by low-risk HPV types, rarely by high-risk HPV types. The cervix and the vagina may be involved, like in this case, as well as the vulva and the perianal areas. In the male, the penis, sometimes the penile shaft, other times the surrounding genital areas, and rarely we may be able to detect penile preneoplastic lesions even in the males. Here we see perianal warts in a male, and for those people who have anal sex, it may be possible to detect anal preneoplastic lesions. In my experience, oral lesions were very rare and occurred mainly in severely immunosuppressed patients, especially HIV-infected subjects. While consistently used condoms provide significant protection against HIV as well as against other sexually transmitted diseases, the impact of condoms is less effective in HPV. Why condom is less helpful in preventing HPV infections? Because in the case of HIV infection, if the condom does not break, there is no risk of transmission. It works like a barrier for blood and seminal fluid. But because HPV is spread by skin-to-skin contact, it is possible for the skin around genital areas not covered by the condom to become infected. In this case, for example, the penile shaft was absolutely normal, even after a peniscopic examination. But under the pubic hair, you can see, and patients can often feel, the presence of several tiny lesions responsible for transmitting the viruses. So condoms should be recommended to protect against other sexually transmitted disease. But we should be aware that it may work less in preventing HPV infections. To reduce the risk of acquiring human papillomaviruses, both low-risk types and high-risk types, HPV vaccines are available. HPV vaccination represents a wonderful tool to prevent many HPV-related diseases, with vaccines containing the most common HPV types, responsible for both anogenital warts and precancerous lesions of the lower genital tract.
Who is to be vaccinated and when?
Which are the most important medicines ever made? Antibiotics, insulin, morphine, aspirin, birth control pills, antihypertensive agents, antipsychotic drugs, and so on. But vaccines are the most effective public health tools for reducing diseases, together with safe food and drinking water. There are now sufficient data on efficacy, immunogenicity, and safety of HPV vaccines. They work, they are able to produce neutralizing antibodies, and they are not harmful. These vaccines are made of virus-like particles which mimic the viral capsid, but do not contain viral DNA or live viruses. They're like an empty egg. Unlike other vaccines, HPV vaccination is also useful in those people who have already been infected by one or more HPV types. Why? First, because people can benefit from other viral types included in the vaccine with whom a woman has not yet been infected. But also because these vaccines can generate high levels of antibodies directed towards the HPV types already acquired by a natural infection. HPV, in fact, has developed strategies to escape eradication by the immune system. Only a little more than half patients are able to produce antibodies directed towards a specific HPV type, but the immune response is often low and delayed. But almost half of women and men are not able to produce detectable antibodies. So this is not a therapeutic vaccine, of course, but it could still help protect from acquisition of new infections, as well as raise immune responses against the viral types already acquired by the subject. We have to bear in mind that vaccination should be promoted before the initiation of sexual activity and exposure to HPV. Here is where the vaccine is most effective. But though the main indication is to prevent disease, because these kind of vaccines are not designed to cure HPV, they can also be useful in women and men who have already been exposed. We have just seen why. Because they may be able to prevent recurrences. And this has already been demonstrated by many studies, where it has been shown that recurrences of anogenital warts after treatment, as well as recurrences of a high-grade disease after proper excision, are reduced following HPV vaccination. The goal of HPV vaccination should be to reduce the incidence of all HPV-related genital disease, including cervical, vaginal, vulvar, penile and anal cancer and precancerous lesions. Reduction in the incidence of genital warts is expected for those receiving the quadrivalent or the recently introduced nonavalent vaccine, and reduction in laryngeal papillomatosis is expected among their children. Laryngeal papillomatosis is a rare but serious disease. Routine HPV vaccination should be initiated at age 11 or 12 years, though it can also be started beginning at age 9. In these cases, we use a 2-dose schedule, the second dose 6 months after the first one. Vaccination is also recommended for females and males aged 13 through 26 years. In these cases, we use a 3-dose schedule, the second dose 2 months after the first one, and the third dose 6 months after the first. But people any age could benefit from HPV vaccination, depending on their own personal history. An important issue: cervical cancer screening must not be discontinued even after vaccination, because we know that protection is never 100%. So nowadays we have very powerful strategies: primary prevention through HPV vaccines, and secondary prevention through screening and colposcopic examination of positive cases. No woman should die of cervical cancer anymore, and we hope to achieve very good results also for the rest of the lower genital tract pathology.